We hope you've been enjoying Health Matters, a global virtual conference. We're going to have a second panel now, and it's on a very important topic that I'm sure you've read quite a bit about in the media. But we're going to start first with a video. This panel discussion is going to be about a multidisciplinary care of persons with concussion at the Boston University Ryan Center for Sports Medicine and Rehabilitation. But let's take a quick look at a video.
The Ryan Center for Sports Medicine and Rehabilitation is a 10,000 square foot facility located behind the Fitness and Recreation Center on the Charles River campus of Boston University. A part of Sargent College, the Ryan Center houses the BU Physical Therapy Center, Athletic Training Services, the Sargent Choice Nutrition Center, as well as physicians from Boston Medical Center who specialize in the areas of sports medicine, family medicine, and orthopedics. With multiple disciplines all represented under one roof, the Ryan Center staff is caring for an increased number of patients who have sustained a concussion. Patients start with our sports medicine physicians, who begin the evaluation process. If concussion symptoms persist, patients may be referred to another discipline available at the Ryan Center to obtain the specific treatment that meets their needs. This referral might be to the BU Physical Therapy Center, where they may see a vestibular specialist, or to a fellowship-trained manual physical therapist to integrate the cervical spine in their care. Referrals may also be made to speech-language pathologists. These professionals can help clients who are experiencing high-level language and executive function symptoms related to a concussion. Additionally, BU athletes receive treatment at the Ryan Center. The athletic trainer for each team leads the care of athletes who have sustained a concussion. Through this comprehensive approach, the professionals at the Ryan Center and Sargent College are providing evidence-based care for the BU and Greater Boston community.
We're so fortunate to have the Ryan Center at Boston University. Now we're going to get to interact with 6 panelists, and each one will introduce themselves.
My name is James Camarinos. I am a physical therapist and the clinic manager of the BU Physical Therapy Center, which is a part of the Ryan Center. I'm a graduate of Sargent College, and I've completed a fellowship in orthopedic manual physical therapy.
My name is Douglas Camo. I'm the Medical Director for Athletic Training Services here at Boston University, in addition to Medical Director for Sports Medicine at Boston Medical Center and Director of the Primary Care Sports Medicine Fellowship. I did medical school training at University of New England, residency at Tufts University in Family Medicine, Wake Forest University for Sports Medicine Fellowship, and love being here at Boston University.
Brian Vesey, Senior Athletic Trainer here at Boston University, and our unit provides athletic training services to all varsity sports, club sports, as well as the ROTC programs here housed within Boston University.
My name is Lisa Brown. I'm a physical therapist here at Boston University as well, and a clinical assistant professor in the Doctor of Physical Therapy program here at BU.
My name is Chad Clements. I'm an athletic trainer, a clinical assistant professor in the Department of Physical Therapy and Athletic Training, and the faculty director for clinical education in Sargent College.
What an impressive group of panelists. We've got some good questions for them. So how is Boston University and the greater Boston community served by you at the Ryan Center?
So first, thank you, Karen, for having us today. I think I can speak for the panel and say we're all excited to be here for this opportunity. The Ryan Center serves the entire BU community. From the standpoint of a point of access, it varies. Important to the College of Health and Rehab Sciences is that it serves as an educational facility, first and foremost. And so just in the past year, we've had over 70 students from both the programs in athletic training and physical therapy complete clinical experiences with the clinicians and the patient populations that are served there. It is a healthcare facility and point of access to healthcare for more than 2,000 students who participate in either varsity student athletics, club sports, and also the ROTC program here. And so their point of access to the Ryan Center is through athletic training services. Cam is going to speak a little bit more about some of the other patient populations, but I do want to mention, too, the connection to the Boston community. In particular, one that I'm mostly closely involved with is a partnership between Sargent College, Athletic Training Services, and Chelsea High School, which is an urban high school with a mainly underserved population. And through that partnership, we're able to provide athletic training services and healthcare to the student athletes at Chelsea High School.
So for the non-athlete, especially here at BU, we are open to any and everybody that wants to come. So most patients that come to the Ryan Center, the primary touch point is Dr. Camo and his group of primary care sports medicine physicians. As he is involved with BU, Boston College, and Emerson, we see a wide range of student athletes as well as non-student athletes, any student that has sustained a concussion or any person from the community sustained a concussion. The process of which the referrals come to happen, we're going to get into later based on our evaluation process, but some of the external patients to the student athletes might come to the BU Physical Therapy Center, which, as the video showed, is a part of the Ryan Center, where our group of physical therapists might try to differentiate which component of care is most integral to that person's recovery, and we can go from there, following up with Dr. Camo and his group of physicians.
Great, thank you. So, we can't help but pick up a newspaper, listen to the news, and hear something about concussions. So, can you speak to what a concussion is? I think that's really important. Why it's such a general health problem today?
Concussion, to put it simply, is a pathophysiological process that occurs in the brain after a patient or a person sustains a blow to the body, head, or neck. The symptoms can be neurological or clinical symptoms that can follow related to a functional disturbance that's caused in the brain. Symptoms can vary but may include headache, fogginess, a sense of dizziness or imbalance, memory loss, and for many individuals may last just a few minutes or even hours, but do resolve over fairly quickly. But for some individuals, symptoms may persist for a longer period of time, and they'll continue to have these complaints for weeks or even months. There are many factors that can be involved in prolonged symptoms, and this is where you see much of the literature or the media following these individuals. It can be a history of a neurological problem, such as a migraine or learning disability, prior concussion, especially if it's recently, or the age of the patient. And these are the cases that can be challenging to manage and require a multidisciplinary approach similar to the one that we have here at BU.
Thanks. So when a concussion occurs, what are some of the first steps of assessment and recovery that's happening at the Ryan Center?
So in talking about initial evaluation of a concussion, one thing unique to my role here as an athletic trainer is that our group is usually on the field with our patient panel whenever these injuries occur. So in looking at those steps from an evaluation standpoint, I think the first thing is to make sure that the patient is alert and oriented. So if there's an unconscious individual, we don't initially concern ourselves with concussion. Rather, we would rule out any significant injury and make sure their airway is open, they're breathing, and that they have circulation. And from there, we would rule out any potential cervical spine injury. But most of the times when we talk about this concussion, we're dealing with injuries that are with conscious individuals. So the first thing, and this seems obvious, but we want to remove them from physical activity. That can be a challenge sometimes in sports based on the rules and the access to the individual that might still be in the course of play at the time that they might be exhibiting some of the symptoms that we notice from afar. Once we're able to remove them from activity, I think we start our evaluation with assessing their vital signs for two reasons. One, to make sure that there's nothing immediately concerning for a more significant injury than concussion, but also to have a baseline so that we can measure that against moving forward should they decline while we're evaluating them. Following that, we follow a standardized protocol that mirrors consensus statement recommendations of what's known as a SCAT-3, which stands for the Sport Concussion Assessment Tool. That includes a litany of tests such as orientation to time and place, a graded symptom checklist to evaluate how the person's feeling at that time, coordination examination, neurological screening such as sensory and motor, potential identification of sensory and motor deficits, as well as a cognitive assessment and potentially balance testing. And we try to put all those things together because when we look at concussion, there's not one sign or symptom that's unique to that particular pathology. Rather, there's a host of symptoms, as Lisa mentioned before, that may manifest in other pathologies as well. So we try to get an overall picture of how that person is. And ideally, we want to be able to compare that to baseline measures that we've been able to take of them prior to participation in sport. I think the final piece that I would add to that is obviously once if they're diagnosed with a concussion or there's a suspicion of concussion, that they don't return to activity that particular day and that they follow up with the appropriate medical provider, as we've identified here on the panel with the number of individuals that we have at our disposal. And then educating the patient and potentially another individual that might have access to that patient later today should they decline, whether that's a friend, a roommate, a teammate, whatever that may be. In that it may seem that like they have a concussion now, but really the critical time is within the first 2 to 3 hours following that initial injury. Those are times where we might suspect a more significant injury, such as an intracranial bleed, might manifest symptoms where the individual's vital signs would decrease or decline, and they might exhibit more significant symptoms. So that's the period of time we really want to educate them that they're watchful of how they're feeling. Aside from that, the final recommendation would be that with a concussion, that they would exercise a period of symptom-limited physical and cognitive rest following that injury, where they're trying not to exacerbate any symptoms that they're currently having until they follow up with us in whatever time frame is appropriate.
I would just follow up also, Brian, particularly with younger patients, particularly at the high school level, for example, is that educating their parents or their primary caregivers is also quite important along the lines of the signs and symptoms that might indicate more significant injury, in which case we'll want to tell them that they should take them to the emergency department, but also to specifically identify what physical and cognitive rest really means for their child. It doesn't just mean that you're going to be out of school and out of sport activity, but also to consider what activities they're doing with their friends, time on the screens, tablets and computers and televisions, and to help them to identify the reduction that would be appropriate for each of them.
Great. This is really important advice, and I hope our viewers are really taking notes on this. I have another question I want to ask. What is the current role of imaging and medication in acute management of concussion? And how about when symptoms persist? And you mentioned some of that already.
Yes, so I'll take that question. And prior to answering that question, I think we're just going to talk briefly about the role of the student athlete, their parents, and also the community, because we have an increased awareness of concussion and almost in a pandemic in our country because of the new guidelines for concussion and realization. So with higher exposure, with higher hit counts, because student athletes starting sports at a younger age and also playing sports 24/7, 365 days a year, they actually have an increased risk for concussion. So that's just something to become aware of, and especially in the state of Massachusetts, the MIAA, which is the high school associations, have mandated that coaches and also parents and student athletes take concussion training on a web in addition to our healthcare providers so that they can have earlier awareness. With that being said, as far as initial evaluation for concussion, we typically don't get any imaging for any diagnostic concussion that is not having any further symptoms. So typically, if in the evaluation of a head injury, unless somebody is having concern for an intracranial bleed, which would mean that they have either a blown pupil or having some type of droop or having type of weakness, we typically would watch them on the sideline, as Brian already presented earlier. If that student athlete starts to decompensate over the period of the game and we need to get imaging, typically would send that person to the emergency room and obtain a head CT. But otherwise, if somebody does have a diagnosis of concussion, we do not necessarily need to get imaging on them. If someone is exhibiting chronic symptoms or more plateaued symptoms over a 3 or 4 week period, if they see us in our concussion clinic or in the athletic training room, we may obtain a brain MRI without contrast to see if there's any type of organic reason or brain mass as a reason why that student athlete is still having symptoms. And finally, functional MRI is something that's currently being studied as far as seeing what areas of the brain are affected with concussion, but currently that's still being researched and there's no guidelines for management on that imaging at this time. As far as medication use in concussion, our favorite medicine to start with is acetaminophen. Acetaminophen, or brand name Tylenol over the counter, has been shown to help with headache in concussion. The reason we like acetaminophen over other medicines is mainly because it does not cross the blood-brain barrier and would not necessarily worsen any type of concussive symptoms. It's also tolerated very well on the stomach, and an athlete can readily obtain that medication as well. Typically, when we do medicate our athletes for headache, we do want to make sure that when they say they're symptom-free without that medication. If someone is still symptomatic after a period of about a week, we do consider adding an anti-inflammatory such as ibuprofen to help augment the betterment with the acetaminophen. Typically, those are the two medications we use in the initial stages of concussion management. But if anyone has post-concussive syndrome, medications that have been studied include tricyclic antidepressants such as amitriptyline and nortriptyline, which have been shown to help with headache management for the concussion itself. And also with any type of sleep issues, we use melatonin and also sometimes trazodone for people who are having difficulty falling asleep or sleeping long periods of time. And otherwise, from a medication standpoint, ADHD and other stimulant medicine are not typically recommended unless an athlete or a concussed patient has a diagnosis of ADHD prior and takes that on a regular basis.
Wow. That was a lot of information.
Yeah, sorry.
That's great, but you did answer the question, so that was good. You mentioned post-concussion syndrome, and I think that we need to better understand at what point does a concussion then be categorized as a post-concussion syndrome, and what's the process by which someone would seek out care? You mentioned some of that, but maybe our viewers would like to hear a little bit more about that.
Absolutely. I think that when we talk about our concussion management in our concussion clinic, we don't see every student athlete or patient weekend warrior who comes in exactly the day after they have a concussion. Sometimes if someone plays basketball on the weekends or football on the weekends and gets hit and they have concussive symptoms, they may not seek care for a couple weeks and they may still be symptomatic. As far as post-concussive syndrome, technically we normally use 3 months as a guideline for post-concussive syndrome, but more in the acute setting, we start to think about doing other things and other management for concussion rehabilitation of the 3-week mark or even a little sooner than that. There's research coming out of SUNY Buffalo on sub-therapeutic cardiovascular exercise for concussion management because of the aforementioned athletes who are used to exercising 24/7, 365. You tell them to rest, they start to get down, depressed, anxious, maybe not sleeping too well because they're used to doing something every day and now not doing it. So adding a sub-therapeutic exercise, by sub-therapeutic we mean that they're going to exercise to a certain point of their heart rate but not a maximal load, and then they go on the treadmill for about 20 minutes and make sure their symptoms are not exacerbated by that time and see if they can do better the next time as well. So that gives a student athlete something physical that they can do but in a short period of time, and we can better judge that the next day provided they were not symptomatic with that. In addition to that, from our initial gateway into our concussion clinic, we would evaluate whether a student athlete or a patient that sustained a concussion would have any vestibular rehabilitation needs or cervical/manual therapy needs by simple screening on balance testing and also manual treatment and palpation of the cervical spine in addition to the trapezius. And I'll turn that over to Lisa. Yep.
Within our clinic, we have both vestibular and manual specialists, and from the vestibular physical therapy point of view, what we often see are persistent deficits in oculomotor function and sensory integration in patients that contribute to many of these post-concussive problems that patients will have. Many of their symptoms can be complaints of dizziness, imbalance, headache, or simply fatigue. And so we will utilize oculomotor, vestibular, and oculomotor screening tools that can help identify some commonly oculomotor functions that are impaired with concussion. We will utilize equipment such as Fresnel goggles to identify deficits such as positional vertigo or oculomotor deficits that are unable to be observed in the presence of visual fixation, as well as assessment of autonomic function. So we also understand that autonomic dysfunction with individuals can play a role in persistent symptoms and return to activity. Once we have an understanding of what some of those vestibular deficits are, often patients will have cervical screens as well.
Yeah, so the sort of process, if you keep walking down the line, is we're trying to tease out primary systems that are involved. And if you look across the literature, the work out of Buffalo, there's fairly extensive work in the vestibular system. It seems that those systems can be primary generators of symptoms in the person post-concussion. What is starting to emerge is to look at the cervical spine as well. Now, if you think of the mechanism of concussion, most, if not all, involve a blow to the head, which would then transmit force to the neck. Now, if you read most consensus statements, which guides practice in many areas of the country and world, in fact, the cervical spine is usually mentioned as a sort of other condition, in that the person might have neck pain, whiplash, something like that. What is starting to emerge in the concussion patient and even the non-concussion patient is the role of the cervical spine in symptoms that sound like headache, dizziness, imbalance, lightheadedness. And the reason for that is that the upper cervical spine has very intricate connections to the vestibular system as well as the visual system. And any imbalance in the coordination of all three of those can result in some degree of either primarily the neck causing some of these symptoms, or at the very least, the cervical spine contributing to them. So through both evaluating their proprioceptive and kinesthetic awareness of the neck, as well as identifying any manual therapy intervention that needs to be done, that kind of rounds out our evaluation process to try to highlight what primary system is producing this one particular patient's symptoms.
Well, it sounds like optimal care requires multiple healthcare providers. Could you walk us through a case study, perhaps, of a person that you followed from the initial injury through a duration of time that perhaps exceeded what was to be expected?
Sure, Karen. I think that it would be good actually if we went over a couple cases that kind of fit each of those different criteria that were mentioned by my colleagues before, with the idea of some potential neurogenic or cervicogenic cause of symptoms secondary to the concussive force. The graded symptom checklist that I had mentioned before that we will typically utilize for the initial evaluation as well as subsequent screenings in tracking patients, those symptoms are often characterized into three categories, one being physical, one being emotional, and one being cognitive. Doug and James had offered some successes that we've seen with the Buffalo Concussion Treadmill test, specifically to some of the physical symptoms that patients will experience in that post-concussive syndrome. With our patients, as Doug mentioned, we'll typically implement that somewhere between the 2 and 3 week mark once we're comfortable that the symptoms may actually be coming from something other than the initial reaction of the concussion. The literature suggests that most concussions, most of the time, clear symptoms usually within the first 7 to 10 days. So around that 2 to 3 week mark, we feel more comfortable that we can start to implement these protocols. And it's really interesting what we're finding with it as a differentiation test to determine whether or not their symptoms would increase with physical activity, meaning that they might be physical symptoms as a result of the concussion, or actually stay the same if not decrease with physical activity, which might be due to some other factors. measures aside from the concussion. But one particular case study that I think is interesting to mention is an NCAA championship caliber athlete that we had that was able to return to full activity with no deficit in sports participation or performance and no symptoms. He went through our entire protocol from a symptom standpoint and had returned to baseline on all of the measures of cognitive function that we were able to implement from a clinical standpoint, would still report back to us about 6 weeks later after being involved in activity that he felt like he was still struggling in school, and there were certain concepts that he wasn't able to grasp that he was able to prior to the injury, and it really made us think what could we do as a more collaborative approach to get someone else involved. And as a result of that, we referred him to some of our colleagues in the speech and language sciences, and through their evaluation they were able to identify some deficits that he had in higher level language skills and executive function that the clinical tests that we have for cognitive assessment aren't sensitive enough to pick up. So through that evaluation, it was both helpful for him to understand that there wasn't necessarily something wrong with him, but it was a result potentially of the injury. But they could also offer strategies for him to try to work through some of those issues. And through subsequent evaluations of them, they were able to demonstrate benefits. So for him to return back to more of a normal learning progression, not just athletic activity. So that's one example of some of the cognitive symptoms that may progress past that normal period that we would suspect a concussion would last. Another example is when we have patients that have emotional symptoms that last longer than we would suspect the normal concussion would last. And that is really an interesting factor, and there's really two categories of patients that we look like with that. There's patients that may have mental illness prior to suffering the concussion, and that concurrent mental illness may be difficult to manage with the concussion symptoms on top of that. And there's also patients that will manifest mental illness, specifically depression or potentially anxiety, after suffering the concussion. And in those cases, we try to identify the triggers for those things. Obviously, the individuals with mental illness that need to be seen by a physician, we would refer to behavioral medicine provider that we feel is appropriate for that individual to get the treatment that they need. But we've also used sports psychologists in the past when we find that some of the symptoms are more around being nervous or anxious about returning to sport. Not necessarily that of a depressive nature, but just feeling uncomfortable reintegrating back into the team environment. And some of the coping skills offered by the sports psychologists have been beneficial as well. So I think the overall point that we would make is that the multidisciplinary approach is one that we really try to put the patient in the center of those care decisions and identify through collaboration with all of us up here who the best provider at the appropriate time would be to treat that individual.
Yeah, I would add to that as well. In terms of an interprofessional approach, having a bunch of healthcare providers is obviously quite beneficial. And some other folks that need to be involved as well, particularly at the high school level, is in addition to the athletic trainer and the nursing staff, is to bring into the mix the guidance office, social work if that's a possibility, and the administration. And two examples at Chelsea High School that I can think of where that was really a great that we had sort of developed this interprofessional concussion management team. One patient who the outcome was good, and at the end of the day, his symptoms and concussion resolved in a normal time frame. But without the communication among those groups of individuals, we may not have identified that particular student had a home environment that was not going to be conducive to him for physical and cognitive rest. So for him to stay home from school was actually probably going to be worse for him in the long run. And so we were able to work out a scenario where he was able to actually come to school, be in the nurse's office or in the health office, and get the care that he needed there. A second one, and so the outcome ended up being great. A second one where it was a patient who actually did have quite a long recovery, again, without the communication among the group, and in particular, in this case, the administration. I'm not sure what would have happened, would have been what happened in this case, which was they identified that this is really no different than what they call a 504 accommodation. So for any student with a disability, they, by law, have to receive accommodations, and they saw this as something very similar. And so they were able to develop essentially an IEP for that particular student so that she could have a successful return back to school and then eventually back to physical activity.
Great. You shared some really interesting case studies, and I'm wondering if now if you met the person a few years after they sustained the concussion, would the process that you've been describing be different? You know, what happens if they had a history over years of multiple concussions? Would the process be different?
Yeah, so as Lisa mentioned earlier, the minute you add a history of concussion, the entire expectation of their care and recovery changes a little bit. One patient in particular that we'd like to highlight, Doug, myself, and Lisa had shared in recent years, she had a 12 concussion history within a 10 or 11 period of time, which is a significant amount of concussions. Very often in fact, people can't identify exactly how many they've had. 12 was maybe even ballpark. So that is a significant concussion history. Now, over the years that she had sustained these concussions, she's seen many healthcare providers, some in a very formal setting, some in sort of passing. At the time that we met her, she hadn't formally been with anybody in years, but she, like many people that all of us see now, was extremely well read. She knew as much about concussion of any person I've ever met. And the benefit of that is she was all in. She was fully invested, and it was an absolute joy to work with her. The challenge that she was starting to find was she was implementing elements of some of the things we've talked about today into her own recovery, but never quite the right dosage. She can never figure out how much of one thing to do and how much of something else not to do. The big change that sort of prompted her to come to our clinic was she started to have significant neck pain as well as some paresthesias down her arm. So that prompted her to come in, and because of that primary symptom, we initiated with sort of care around her cervical spine. So some of the first things that we started to do were about the mobility of her thoracic spine, mobility of her cervical spine, and looking at things like that we would with most people with neck pain. Now, as I mentioned earlier, the proprioceptive and kinesthetic system of the neck can be a big part of these symptoms, and she also had a fairly large degree of lightheaded, dizzy symptoms. So upon evaluating if her cervical spine was contributing to that, which involved a decent amount of her turning her head to do both the testing and the exercise, her symptoms severely were exacerbated. So at that point in time, seeing that response was happening, I thought it was appropriate to refer her to vestibular specialist, Lisa, and she can kind of take the story from there.
And so, as Camden said, many of our patients are able to get information, often through individual healthcare providers or from the internet. And while she had been seen in many clinics, I think the benefit of being in a multidisciplinary center where we can have a conversation even, within the same room, is that we were able to put a lot of the pieces of her story together. So she had received care before, but it was often, very individualized. And so with this patient, she had tried to self-apply some vestibular exercises that she had off of the internet, which can often, if they're not applied correctly, or if they're not addressing the right system that is actually impacting the patient's problems, they can exacerbate and often make their symptoms worse. So we were able to do a comprehensive exam, as well as go through her history to understand when she was feeling her symptoms, and then tailor a program, a gait stabilization program that specifically identified the deficits that she was having, and able to apply it to the functional situations that she was having trouble with.
Yeah, so she ended up seeing me as well during that time, the combination of the vestibular and the cervical rehabilitation, but we felt at the time, because of her clear exacerbation of symptoms, we had to order some imaging to ensure that there wasn't anything else going on with her neck itself. So she had seen me in clinic, and we had ordered an x-ray, which did show some degenerative changes in her neck from her years of playing her sport, which was soccer, and then also there was concern because she had a decrease in her normal lordotic curve of her cervical spine. We had ordered cervical MRI to evaluate whether there was just the degenerative changes or if there was some discogenic changes as well, and she was found to have some nerve foraminal narrowing on the cervical spine, meaning that there is a more of an inflammatory narrowing of the nerves coming out of the spine. We did give her some medication to help counteract that, and she had a great result with that. Unfortunately, with the medication we use, it's more of a temporary medicine to see if it will work. So she was subsequently set up to have epidural steroid injection in that area.
So just for the sort of timeline of how she went, and a bit of an update also, which I think most everyone knows because I just got this update. In the very beginning, she had sort of tolerance to one or two inputs. And by inputs, I mean she could maybe sit at her computer and study. She was working on her PhD for an hour or two, and then maybe go exercise, CrossFit was the thing she had recently gotten into, for an hour, and that would be it. And that would sort of wipe her out for even a day or two. We worked with her consistently for about a 5-month period of time. By the end of it, she had significant improvements pretty much across the board, especially in her tolerance to these inputs. So whereas she could only work for an hour or two, the work that we had done and some of the accommodations she had gotten with her school, including things like a screen reader, she could now work for hours on end towards the end of her thesis. The other thing that she was able to do was really progress her ability to exercise. So by the time she left, she had participated in sort of elements of some of the CrossFit sort of competitions, all with accommodations, some of which she spearheaded in the community group, which was fantastic. When she had left Boston, she had moved away from the city. She moved and had the opportunity to go to a different concussion center and really devote a month of period of time to her recovery. And she had gone through in that period of time a very similar multidisciplinary elements of care, with ocular rehab being the one thing that was added, as well as some more specific exertional training. And she reported pretty much continued improvement in that she can work now on her PhD for many, many, many hours without really exacerbating her symptoms or setting her up for days of symptoms, which is what her pattern had been. So we thought it was just a great case to highlight because it goes to show, I think, the multiple elements that a patient can display when they've had years of symptoms and the improvement that somebody can show when they're as committed and loyal to the program as she was.
That was a great case example, and it really underscored each of your roles and the importance of it for the success of this client. So we're going to look into the future. How do you see your professions evolving in the coming years? And where are you going with the Ryan Center? If you want to look in the future, let's tie those two questions together.
So I think I would start specific to some primary care as well as initial evaluation things, both on the sideline as well as in the clinic, that I think are interesting. Is when you get into the research, there's a number of tests, some showing some promise on initial evaluation on the sideline that can be implemented in helping to diagnose concussion. I think one in particular is more of a clinical exam that shows some promise in identifying a particular protein that the levels within the blood appear to be higher, specific to traumatic brain injury. And as those blood tests become more sensitive, there's some promise that there might be a way to utilize those to diagnose more mild traumatic brain injury or concussion, and which is interesting from a diagnostic standpoint, but also from potential return to play ramifications as those levels tend to clear. There may be in the future, we're not there yet, but some utilization of those measures to be a little more objective in decision making as you return to physical activity in those ways. But I think the one thing that I would add as far as things changing from my career, and I would just take a second to address the clinicians, particularly primary care providers and first responders that might be in the audience, is my perspective on how I evaluate concussion in the moment on the sideline has changed dramatically throughout my career. And I think initially I had a mindset of trying to rule out the injury, and now I have a mindset of trying to rule in the injury. And I think that at some level you could argue semantics with my wording, but what it means to me is when you're ruling something out, you're looking for an excuse to say that it's not there. And we had mentioned earlier that there's a litany of tests that might be run that are not individually specific to concussion, but together might present a better picture. And if there's an internal bias from a clinician to say that these 1, 2, 3 measures are negative, they probably don't have a concussion, I think that's the wrong mentality to take in the mindset of ruling something out. Rather, now I really look to rule the injury in, and I continue to try to find a way to say that this individual has one, and the patient needs to prove to me that they don't through all of the tests that I had mentioned prior within that initial evaluation for me to really feel confident that they don't have that injury.
From a physical therapy standpoint, I think we've seen an evolution in understanding concussion better and how we can apply some of our neurological assessments and better measure the impairments that we're seeing with patients. I think what I'd like to see is more standardized outcome measures so that we can track progress over time, particularly with our more chronic patients. Those individuals are more difficult to understand and manage, and I think it would be helpful to see the development in the literature of outcome measures that we can track with these patients.
And from the primary care sports medicine perspective, I look to the international concussion conferences. There's been one every 4 to 5 years, starting in 2001, moving forward, and that has a multidisciplinary approach as well towards what we currently do for concussion, how we currently define concussion, and also then how we manage concussion. I think that from a management perspective, the nice thing is the past 2 conferences have not really changed how we manage a concussion in the sense that we're treating every athlete individually based on their symptoms. I think that more so we're adding in different things we can do to help the athlete feel better, quicker, and also feel safer to go back onto the playing field once they're asymptomatic and completing a return to play progression. I think also the research going on for cardiovascular, sub-therapeutic cardiovascular training is very important, and also improving concussion awareness throughout the United States. And that's more globally, but then as far as our Ryan Center clinic goes, I think that you've heard here about all of our multidisciplinary individuals here, and having a more formalized concussion clinic is where we'd like to go. Moving forward, meaning that a student athlete, a patient calls up our Ryan Center number, they get seen the same day or the next day by a primary care sports provider and one of the athletic trainers to see if on evaluation, if that student athlete or patient is symptom free, then they could start a return to play progression, and working with our athletic trainer daily on that until they're ready to go back on the field. If that person on evaluation is still symptomatic or has more post-concussive symptoms, referring them over for after screening to see if vestibular or cervical rehabilitation would be appropriate for them. Then having that patient follow up with us in about 2 or 3 weeks, and then if anything else is going on, if they're asymptomatic, they would start a return to play progression. If they're still symptomatic, maybe that's time to do further imaging or to look up or medication management if that deems appropriate. So I think having a more organized structure is where we would like to go with the future during this exciting time of concussion management.
Well, thank you so much. For our viewers, if you want to learn more about the Ryan Center, please go to the Boston University Sargent College website, and you'll see an icon there for the Ryan Center. This was really an informative, multidisciplinary panel discussion. I learned so much, and I know you must have too. So thank you, everyone, for being here today, and thank you for being part of Health Matters.